if a patient collapses or if you find someone who collapses by the road, what will you do? You remain close. So if you encounter a patient, any person falling in the center of the road, what will you do? See, the first thing is that have a seat. So the first thing is, before starting any help or resuscitation, you want to ensure that the scene is safe. If a person is lying in the center of the road and you are trying to help him or her, then you are putting your life in danger. So the first thing that you note on reaching any scene is whether the scene is clear to help or not. So once I have seen that the person is at a place where it is safe to help, I call it scene is safe. Then I approach a person who has fainted or collapsed and I check for the responsiveness. Hello, are you okay? Suppose there is no response. Now the first thing I will do is to call for help. Kindly tell the administrator and the CEO and activate the emergency response system. So in many hospitals there is a red button and you press it and there is activation of the emergency. So I repeat, I start from the beginning. The first thing is to see whether the scene is clear. So I shout, the scene is clear, scene is safe. The second thing I do is that I check for the responses. Are you okay? The person is not responding, so I will call for help. Anybody please help, the patient has fainted and collapsed. So now the next thing is I will check for the carotid pulse and the breathing. Now this thing should be noted for 5 to 10 seconds, not less than 5 seconds, not more than 10 seconds. My two fingers are on the carotid pulse and I am counting 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000, just to calculate the 5 seconds. And I note how much pulses I can feel and how much the chest is moving. So suppose there is no pulse and there is no breathing. So the patient has collapsed. Most probably the patient is in cardiac arrest. So what will you do? So you ask a person, number one, bring the mask and the bag so that we can start the ventilation. If a second person is available, he or she can start the CPR, cardiopulmonary resuscitation. And you ask the third person to bring a cardiac monitor and attach the leads. If anybody else is available, you ask him or her to pass the IV line. So when there is no pulse, when there is no breathing, we will immediately start the CPR. And let's say if only one person is available, the person will start with the. So this is the procedure of performing CPR. We place one hand on the lower part of the sternum in the center of the chest and place the other hand on top of it and press it force 1, 2, 3, 4, 5, 6. Now this should be forceful enough to depress the chest by 5 centimeters. The rate should be 100 to 120 per minute and there should be sufficient time for the recoil. So if we are not maintaining the proper rate and the depth, then the respiration will not be enough. At the same time, the other person starts breathing with the mask and the balloon. So usually we press the half balloon and gives tidal volume of 500 ml. Now it should be one breath after every 10 seconds. So we preferably after every 6 seconds so that we have 10 breaths per minute. 10 breaths per minute and 110 compressions per minute. So we have started CPR and we have attached the monitor. Now we will see the rhythm. Suppose there is a pulse and there is a rhythm, there is no breathing. So we will give only the respiration. If the respiration is present and the pulses are absent, then we will concentrate on the CPR. So let's say on the monitor, what are the different forms that we can encounter on the monitor? One is, let's see. So this is P wave, QRS, T wave. So this is normal sinus rhythm. Suppose the PR interval is increased. So what is this? First degree heart block. Increase in the PR, start from the start of the P and start of the Q, or start of the QRS complex. So this is first degree heart block. The second degree heart block has two types, Mobis 1 and Mobis 2. In the Mobis 1, the PR interval progressively increases. So this is one QRST complex normal, but the next P and QRS interval is prolonged, and this is the T wave. So the third one, P and QRST interval are much prolonged. So you see there is progressive increase in the PR interval 1, 2 and 3. So this is Mobis type 1. And in the Mobis type 2, there are, let's say, two P waves and then one QRS complex, P wave, P wave and then QRS. So there is progressive enlargement or lengthening of the PR interval so that one beat is missed. This is type 1 and this is type 2, first degree, second degree, and in the third degree heart block there is complete dissociation between atrial and ventricular fibrillation contraction, so that you may have 2 or 3 P waves and then 1 Q wave, then 2 or 3 P waves and 1 Q wave. So there may be dissociation. There is a dissociation of atrial contraction and the ventricular contraction. So this is sinus rhythm. This is heart block type 1. This is type 2, Mobis type 1 and Mobis type 2, and this is third degree heart block. So if the heart rate, normal heart rate is 72 per minute. So if it is less than 60, this is bradycardia. If it is more than 50, then it is liable to have systemic repercussions. Similarly, if the heart rate is more than, so 72 is the normal, less than 50 is pathological. There is some problem. Similarly, more than 100 is tachycardia and more than 150 is tachyarrhythmia. That means that the heart rate is too. So if these are associated with systemic features, these are called unstable. So what is stable and what is unstable? Stable is when blood pressure is under control, there is no ischemic chest pain, and the mental functions are normal. If any of these things are disturbed, let's say mental functions, blood pressure and ischemic chest pain. Now if any of these is present, it means it is a sign of instability, and if it is present with bradycardia or with tachycardia, we have to treat that. So in case the patient comes and patient is having a pulse of less than 50, so this is bradycardia, what we are going to do? Bradycardia. So this is advanced cardiac life support, bradycardia having. Now if the bradycardia is stable, we will monitor. But if the bradycardia is unstable, blood pressure is less than 90 millimeter of mercury, or the mean arterial pressure is less than 65 millimeter of mercury, or the patient is having there is mental confusion, or if there is ischemic chest pain, then number one, we will give 1 milligram of atropine IV stat. If the condition does not improve within 2 to 3 minutes, then we will give dopamine IV 5 to 20 milligram microgram per kilogram per minute. And if the condition does not improve, then we will give epinephrine 2 to 10 microgram per kilogram per minute. Now, if we have a facility of percutaneous, this is called TCP, transcutaneous pacemaking. We attach 2 leads on the surface of the skin, and in many centers this is available. Very simple procedure, just attach 2 leads on the skin, and this will act as a temporary pacemaker. So this is called TCP. So if the hospital has TCP, we will go for it. Otherwise, we have these 3 drugs. Now coming to the tachycardia. So if the pulse rate is more than 150, what we will do now, if the patient is having unstable tachycardia, we will give adenosine. This is 6 milligram dose, and if does not respond, then we will give 12 milligram adenosine. Now, if there is a pulse, but there is a rhythm on the cardiac monitor, but there is no pulse, then it means there is cardiac arrest. So in cardiac arrest, there are 2 possibilities. One possibility is asystole. Asystole means there is no electrical activity. You will have a rhythm like this, straight line on the cardiac monitor. So if there is asystole, you will give epinephrine 1 milligram IV stat. But if there is ventricular tachycardia like this, or ventricular fibrillation, then you will give cardiac shock. We give 1 cardiac shock and we immediately follow it with CPR. If after second cardiac shock there is no improvement, we will give 1 milligram epinephrine. If after third cardiac shock there is still not improvement, we will give amiodarone or lignocaine. So, summing it up, in cardiac arrest we have 2 options, asystole and ventricular tachycardia. Now there are different types of ventricular tachycardia. One is supraventricular tachycardia. This is the normal rhythm, but it is just increase in the rate. So this is tachyarrhythmia. There is one, this is monomorphic tachycardia with broad QRS. The width or the breadth of the QRS has increased. Another one is a few small rhythms and a few large rhythms. These are called, this is monomorphic and this is polymorphic. And the final is activity like this is ventricular fibrillation. So whether there is ventricular fibrillation or monomorphic or polymorphic or pulseless ventricular tachycardia, there are different types of. In all these conditions, we will either give a cardiac shock or we will give epinephrine if there is asystole. So these are a few drugs. Coming back to the basic thing. Momna, can you repeat what are the basic steps you will do when you see a patient fainting, let's say in the center of the road? Oh, please come here. Demonstrate. You are going along the road and you see a patient hit by a motorcycle, and the patient has fallen in the center of the road. So what will you do? Okay, now let's focus. Hey,
First of all, I'll ensure that the scene is safe.
good. So the first thing you see is whether you want to help, whether you should help or not. If a person is lying in the center of the road and you start helping, any vehicle will hit you and kill you. So the first thing is you make it sure that you bring that person with the help of somebody to the side of the road and declare the scene is safe. So after you declare the scene is safe, what will be the next step?
And then I'll check whether the patient is conscious or not.
How?
Tap the shoulders of the patient and
Okay.
ask, are you okay? Are you okay?
So you check for the responsiveness. You tap the shoulder. हाँ भाई क्या हाल है? Are you okay? क्या हो गया? See if the person responds or not. Okay.
Then I'll check for the carotid pulse.
No, after you have seen the responsiveness and the person is not responding, what will you do?
I'll call for help and
Okay, you will shout for help. Please help. There is a person lying, requiring our help. Call CMO, call administrator, call anesthetist, anybody. Whether you are outside or you are inside, depending on the location, you can't help the person alone. You will call help. Okay.
Then I'll check for the carotid pulse, minimum 5 seconds and maximum for 10 seconds, and I'll count like 1 in 1000, 2 in 1000.
You will check for the pulse and the breathing at the same time. In 5 seconds, you are assessing both. And to count the 5 seconds, you will count as 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000. So you have proper assessment of the time. Not less than 5 seconds, not more than 10 seconds. You want to assess between 5 to 10 seconds both the pulse and the breathing. Okay, so you have assessed the pulse and the breathing. There is no pulse, there is no breathing.
Then depending on the help that has come, I will start with the CPR.
Okay.
Starting with the chest compressions, and the hands should be placed such that they are at the point of the Xiphi sternum, parallel.
Not at the Xiphi sternum. That will break the Xiphi sternum. At the lower half of the sternum. And in the center of the chest, on the lower half of the sternum. Xiphi sternum is the lower edge of the sternum. And it will break if you put your hands there. Okay. So you place one hand, okay, place one hand and put the other hand on the top of it, whether you place right or left, it doesn't matter. But once you have to lean forward so that your whole pressure, the whole body is forcing on your hands. So you lean forward, yes, and press it. So how many compressions per minute?
110 compressions per minute.
Yes, 100 to 120 compressions per minute. And how much should be the depth?
5 centimeters.
5 centimeters. So you have to ensure 5 centimeter chest compression will lead to a proper cardiac output. If you press more, then it is not useful because it has its own drawbacks. If you compress less, then the breathing will not be restored. Okay, so what?
Then similarly for the breathing, we estimate for about 10 breaths per minute, 1 breath after every 6 seconds, tidal volume of 5 to.
Okay, so you attach a mask and a bag and push the bag half, because pushing the bag full will lead to overventilation. So the bags are usually big and you only have to push for half the compression, and this will give you tidal volume. And you count 6 and press it once, so that in 60 seconds you have 10 respirations or breathing. So once you have started CPR, what will you do next?
Then we have to see the cardiac rhythm either through the.
So you will ask for 2-3 persons assistance. So what would they be doing?
One will be on the compressions, one will be on the breathing mask, the second will be on the cardiac monitor, one can be on the IV line, passing the IV line and administering the medicine, and one can be the team leader.
Good. So if you have 4 or 5 persons, you will form a team. One is compressor, the other is on breathing, the third will be attaching the leads and looking at the cardiac monitor. The fourth person will be maintaining the IV line, the fifth person will be CPR course, and the sixth person is yourself, the team leader. So what will you ask them to do? So there is no pulse and there is no respiration. You have started CPR. What is your next line of action?
So then the person who is attaching the monitor will see the cardiac activity and then whether it is a shockable rhythm or a non-shockable rhythm, and what is, if we are having a pulse, whether it is brady or tachy, we'll administer the medicines accordingly. If it is a shockable rhythm, then we'll
Okay,
start.
you can come here.
So, as we already know that the normal heart rate is 72 beats per minute. If it is less than 60 beats, we will label it as bradycardia. And if it is less than 50 beats per minute, it has systemic features, and that is pathological for us. Similarly, greater than 100 beats per minute will be tachycardia, and if it is greater than 150 beats per minute, it will have systemic repercussions as well. So, if the patient is in brady, so in medication, first of all, the first line will be administrating atropine, and then if it has not improved, then we can administer dopamine with a dosage of 5 to 20 kilogram milligram per kg per minute. And the third line will be epinephrine, which is administered at the dose of 2 to 10 milligram per kg per minute. And then if the patient is tachycardic, we administer the first line, we have adenosine. But if the patient is having cardiac arrest, then again we have to see whether it is asystole or whether some arrhythmia is present, which is shockable as well. In case there is asystole, a flat line is present, we have to administer epinephrine only. But in case we get an arrhythmia such as ventricular tachycardias, then we provide the shock to the patient. After giving one shock, we will resume with the CPR, and then we will give the second shock as well and observe if there is any improvement. If even after giving 2 shocks there is no improvement, then we will administer epinephrine. And if after the third shock there is no improvement, then we can either go for amiodarone or lignocaine.
Good. Any questions? Thank you. So,